оценка. Надо лучше только добить. Там у меня получается, знаешь, сколько у меня получается за год? 7. Да лучше еще добить будет 8, потому что у меня 76. Я сколько ровно хотел получить, а так я столько и получил. Я хотел себе 8, получил 8, что у меня 80%.
Вот, ты получил. Иди отсюда, свистун. Chief of the groups, please announce your colleague to be inside of the lecture because only 34 students here. We are 54. Now it's 12:04. Please announce once again your colleague to be inside of the meeting. Светлана Ивановна, 40 уже. Будем начинать. 40 человек.
Ну да, за эти минуты же. Okay. Hello, one more time. We continue our gastroenterology, and today my task is to present you absolutely separate part. We will be talking about the functional gastrointestinal disorders. Tell me, please, do you know what's mean functional? Do you know about these disorders? Who can say me? What's mean functional? No? Safarayan, or turn off your microphone or give me an answer. Thank you. Okay. If you are not ready to answer this question, I will explain you. What's mean functional? Functional, that's mean the disorder where the different complaints, different abnormalities of body activity cannot be explained by structural abnormalities when we use common clinical examination, using anyone, using endoscopic examination, X-ray, MRI, CT, blood tests, different biological, immunological, and so on tests, we cannot explain these complaints. How is that? I will explain you a little bit later. But first of all, functional gastrointestinal disorders are the most common gastrointestinal disorders. These disorders are much more frequent in comparison with organic disorders. In general, to explain how is that patient has complaints, the most frequent pain, patient has different nausea complaints. This may be dyspeptic syndrome, or this may be bowel movement disorders. But different examination using the modern methods of examination cannot explain these disorders. For the first time to explain this situation, Professor Drossman proposed so-named biopsychosocial concept. And the basis of this pathogenesis is the disorders of interaction between peripheral nervous system and central nervous system. Here we have the basis of these disorders. And in the basis of these disorders, maybe three main mechanisms. First of all, that's disorders of peripheral nervous system receptors, as usual vegetative system receptors. Hypersensibility of these receptors. Another group that is disorders of transmissions of this nervous signal. And third and last one is disorders of interpretation in the central nervous system of this signal. I can give you a very simple example to understand these functional disorders. For example, in case of healthy person, and after the meal with a lot of cabbage, for example, or different fructose, a lot of fructose and some, this meal will cause the meteorism, flatulence. And healthy person feels this flatulence only like maybe some discomfort. We can feel this meteorism and interpret only like small, mild discomfort. But in case when the receptors of peripheral nervous system are hypersensible, or the interpretation of central nervous system is incorrect, then this subject feel this meteorism like pain. And this pain may be really serious pain, long time.
Have you got time to discuss your work now, or are you thinking to leave?
This pain may be associated with different...
To live here. She came to live here.
Doamna conferențiar.
Quite a month ago.
One moment,
please. Once the plane is in the air, you can underfast your seatbelt. Да.
Анжела, мы слышим тебя.
Скуда? Да.
Okay, we will continue. And these disorders, this pain may be associated with different another symptoms and complaints. Here, you can see this biopsychosocial concept of functional gastrointestinal disorders described by Professor Drossman. And in general, I explained you this theory, but you can read one more time later. But the most important is that functional gastrointestinal disorders is not mind disorders. It's not correct that all is in the mind. No, it's not correct that these disorders is because that these disorders are psychiatric disorders. That's not psychiatric. That's not psychological disorders. That's disorders of peripheral nervous system, yes. Central nervous system, yes. But peripheral gastrointestinal system. And this disorders is so named psychosomatic pathology. We know this pathology long time. The very simple names was first, for example, stomach neurosis or intestinal neurosis. And there were different classification with more systematized classification from 1978. Then was created a group, international, in general, worldwide group of experts which analyze these functional disorders and elaborate and propose criteria for diagnosis. And as you can see, first criteria was in 1989. And now we have last edition, last review of this criteria, Roma criteria 4. Roma, that's because the first meeting was in the Roma, but the name remains. We have practically for any organic gastrointestinal disease parallel functional disorders. In the classification of functional disorders, we have esophageal, gastroduodenal, bowels, and another, and separate group of pediatric disorders. Let's see classification of gastrointestinal disorders. Here you can see esophageal disorders, functional chest pain of esophageal origin, and another interesting functional heartburn, another one interesting globus. We will discuss our functional dysphagia. We will discuss these disorders a little bit later. But now you should understand that parallel with them, no, I can say probably the main esophageal, the most frequent esophageal disease, that is gastroesophageal reflux disease, yes, GERD. And parallel with GERD, it may be functional heartburn. Heartburn functional, I will explain you a little bit later. Here, you can see the functional disorders from stomach origin. And you remember, I hope, that the most frequent organic disorders that you know now, that is different form of gastritis, that is ulcer disease, not maybe cancer, polyps, but parallel and much more frequent, it may be functional dyspepsia. What's mean functional dyspepsia? That means presence of symptoms with no signs of gastritis. Do you remember that gastritis is morphological diagnosis? We should have morphological confirmation, evidence of chronic inflammation to confirm presence of chronic gastritis. But if we do not have, but patient has the complaints, different dyspeptic syndrome, it will be named this situation functional dyspepsia. We will discuss it later. And not only functional dyspepsia. Here we have very interesting situation. No, okay, functional aerophagia, that's clear. But it may be, for example, functional nausea and vomiting. Nausea and vomiting with no concrete confirmation, evidence that we have any organic very interesting pathology we have here. Cyclic vomiting syndrome. That means periodical vomiting with no organic cases for this situation. Another is the best probably known, that is functional bowel disorders. And first of all, irritable bowel syndrome. But not only irritable bowel syndrome. We have here functional constipation, functional diarrhea, and functional bloating. No, and these ones very specific. There's the constipation induced by opioids. But that's the not only functional. Not only functional. This disorders is included here. I can send more for scientific aim to study the difference and to study the features of these disorders. But the most frequent is irritable bowel syndrome and functional diarrhea, functional constipation, functional bloating. The same we will discuss it more detailing. One of the most severe situations with the most severe pain is functional gallbladder and especially sphincter of Oddi disorders. That is the main and the most frequent disease of biliary tract. And parallel, as I said, we have the disorders of anorectal and disorders of neonates period and children period. Let's leave this one for proctologists and this one for pediatrics and pediatric module. Now, I would like to give you the main approach to the care of patients with functional gastrointestinal disorders. Indifferent of the localization of these disorders, we should respect some rules. And the most important probably is to establish a normal, friendly, therapeutic physician-patient relationship. What that mean? That means obtain the history by discussion with patient, but non-directive, patient-centered interview to determine how much the patient understands about the illness, to explain of the disorder, to explain correct this disorder, not to say, in any case, not to say, your problem is in the mind. The problem is not in the mind. The problem is in the hypersensibility of peripheral nervous system, hypersensibility of receptors in stomach, receptors in intestine, in sphincter of Oddi, and so on. If it's possible, you should try to find the stress factor which influence these disorders. And you should discuss with patient about these stress factors and about how to ameliorate this stressful situation. You should involve the patient in the process of diagnosis and in the process of treatment. Why? Because we do not have very effective treatment in this very frequent situation. We need patients' help, patients' understanding, and patients' belief in the good treatment results. Then, that was very general recommendation how to talk to patient with functional disorders. Here you can see more concrete recommendation in the function of the grade of severity of these functional disorders. In majority of the cases, when functional gastrointestinal disorders are of mild degree, we do not need specific treatment. We should explain the situation. We should recommend healthy diet, healthy lifestyle, and maybe sometimes we need only symptomatic medication. After this explanation, after this education, the majority of the patient, 95% with mild symptoms, will continue his healthy life. Will not address to doctors. They understand what problems they have and they can control this situation themselves. Then, in case of moderate symptoms, we do the same. We give the same recommendation. We give the same behavior recommendation and another, but here it may be necessary psychological treatment, not only symptomatic, but and psychological treatment. You can see here cognitive behavior therapy. If you think that that is something very, very special, you are not right. Cognitive behavior therapy, that's your conversation with person, with subject, and your explanation and your recommendation about how to live healthy life, how to modify healthy lifestyle, how to relax, and another methods is different types of relaxation, including and absolutely non-specific, like for example, spa, and more specific, that is hypnotic therapy. And severe functional gastrointestinal disorders, that's really very serious situation. Functional, no organic, but very difficult to treat, very difficult to achieve good result in treatment. Severe symptoms, that means that the patient lost his not only work activity, but and holiday activity and rest activity. But to treat this patient is very and very difficult, as I said, and in majority of the cases we need antidepressant treatment. Sometimes neuroleptics, but in majority of the case, antidepressant treatment. Okay, that was general approach. Let's discuss some special diseases, special disorders. First of all, functional heartburn. You remember gastroesophageal reflux disease, your first topic. I hope you remember. What is in the basis of gastroesophageal reflux disease? Clear that in basis is reflux. Reflux of stomach contents in esophagus. Reflux causes receptors in the esophagus, inflammation of a mucosa, and more deep affectation later. But in the basis is reflux. We have different methods to confirm presence of this reflux. For example, we can use pH metry, we can use impedanceometry, we can confirm by the complication of gastroesophageal reflux using endoscopical examination, but only a complication. But there are situations when subject said, now I have heartburn. But we doing in this moment pH-metria or impedancemetria do not see any reflux. That means that this feeling of heartburn is not associated but significant reflux. These feelings appears because the hypersensibility of receptors in esophagus, and this hypersensibility causes the appearance of symptoms with no significant signal. It may be some smallest reflux, but patient said that he has heartburn. That's what about the criteria? I would like to say you first of all about these time criteria. These criteria are common for practically for all functional disorders. This criteria is that symptoms must be for the past, must be at least 3 past months, with onset of system at least 6 months before. That means that we need to put chronic disorder, the history of 6 months, and to understand that it is active disorder, to have these symptoms last 3 months. But later, we have different frequency. Frequency of appearance is different in different disorders. Here, for functional heartburn is recommended not less than twice a week, because less than twice a week, that's not pathological situation. That may be normal situation after the certain meal. But if the heartburn is more than twice a week, more than 3 months, with onset more than 6 months, it's clear that that is chronic active situation, functional heartburn. As usual, heartburn that is burning, retrosternal, pain or discomfort of burning character, with no relief after anti-secretory treatment or anti-acid treatment, and when we do not have any evidence of gastroesophageal reflux disease. Clear that gastroesophageal reflux disease must be excluded to put the diagnosis of functional heartburn. How to, another interesting situation of functional esophageal disorder, so named globus. What is globus? Globus is the situation when patient feel like foreign body in the throat. This foreign body in the throat appears between meals, because in time of swallowing, it will be not globus, it will be dysphagia or odinophagia, disorders of swallowing on painful swallow. But globus, that's this feeling of foreign body between meals. We do not have signs of dysphagia or odinophagia, and we do not have any organic pathology in gastric, in stomach, or in proximal esophagus or in throat. We do not have gastroesophageal reflux evidence or another organic pathology of esophagus. Very frequent. It's not rare disease. It's very frequent disease. But in majority, not in majority, but in a big part of these patients are with diagnosis of thyroiditis or another pathology of thyroid gland. Incorrect, because the thyroid gland as usual are lower, but feelings are upper, and thyroid gland not frequent cause any pain or discomfort. Discomfort mild maybe, minimal. But here the persistent situation of node or foreign body in the throat. Another group of disease, very important, that's functional dyspepsia. What is functional dyspepsia? To be easy for you, I can say very not usual proposition, but is functional dyspepsia, that's gastritis-like or ulcer-like situation with no signs of gastritis or ulcer, gastric ulcer or duodenal ulcer. But if to say more correct, functional dyspepsia, that's presence of symptoms originated from stomach or gastroduodenal region in the absence of any organic systemic metabolic diseases that can explain these symptoms. Functional dyspepsia is much more frequent than organic disorders. Here you can see the diagrams of the frequency prevalence of different gastroduodenal disorders in different years. Here this is from 18, 19, here from 19, the data from 19, here the data from 2000, but all these studies showed that the most frequent pathology with gastroduodenal symptoms is functional pathology. But ulcers is 2 times less frequent than functional. What criteria for functional pathology? You remember about that we use Rome IV criteria. What criteria according to Rome IV classificator? Functional dyspepsia, that's postprandial fullness, but not patient doesn't feel pleasure because of this fullness, but bothersome, unpleasure, postprandial fullness. Another is early suscitation. What does this mean? This means that the patient said that I eat 2-3 spoons and I feel that I cannot eat more. I am full. Sometimes appears pain after they eat, like in case of gastritis or burning situation. In general, this burning feeling is very typical for functional disorders. In case of organic pathology, we do not have frequent burning pain. As usual, another characteristics of pain. Functional, that is very frequent feeling of burning. And clear that we don't have no evidence of structural disease. The same, we have Time criteria, 3 months and 6 months. Functional dyspepsia may be divided into 2 big groups. First one is named postprandial distress syndrome. Postprandial distress syndrome, I repeat, this syndrome we can name gastritis-like condition. The complaints and situation is like in case of gastritis, but we do not receive the evidence of chronic inflammation in the stomach using histological analysis. This postprandial distress syndrome includes first 2 from general dyspeptic criteria. That's fullness after ordinary meal and yearly satiation after ordinary or less than normal volume of meal. And this must be several times per week, at least several times per week, to confirm active chronic disorders. It may be bloating. Sometimes patients explain how that this bloating is only in the upper part of the abdomen. Another functional dyspepsia, another form of functional dyspepsia is epigastric pain. And here I can say that it was the old name of this situation, ulcer-like dyspepsia. Here, the main 2 symptoms are last 2 from general criteria. That is burning pain. Sometimes this pain is of moderate severity, but sometimes it may be really severe pain. Pain in epigastrium. The same, it must be at least once per week if we are talking about pain that is not stable, persistent pain, stable pain, or pain with increased intensity. That is very alarming symptoms. We should do endoscopy and exclude cancer. But in this case of functional, we have intermittent pain. And this pain may be associated with bloating and another dyspeptic symptom. What to do with functional dyspepsia? I said you that functional disorders, and especially functional dyspepsia, functional gallbladder disorders, functional intestinal disorders are very frequent, very frequent. And these disorders are typical for young people, more typical for young people. And we cannot recommend, we may not recommend the endoscopic examination for all these big number of practically healthy persons. What to do? How to put correct diagnosis? First of all, having these clinical symptoms of pain or bloating or fullness, we should evaluate presence or absence of alarm features, alarm symptoms. For what? To exclude cancer, to exclude signs of severe organic disease. We should exclude weight loss, recurrent vomiting after the meal and with contents of meal. We should exclude progressive dysphagia any odinophagia, any blood in the vomiting contents or in another blood, any laboratory test modification are alarm features. These alarm features exclude the functional pathology and recommend us to do endoscopic examination or another examination, but we should put organic diagnosis in case of presence of alarm symptoms. In majority of the cases, here we have one more alarm symptoms I don't have on the slide. That is the age of the onset of disease. In case of onset, in age more than 45, 50, for the first time appearance in age of 45, 50, there's practically alarm symptoms because there's the age with high risk of organic pathology, cancer especially pathology. That is why in appearance of these first symptoms in the age more than 50, we recommend endoscopic examination and another examination if it's necessary to put organic diagnosis. But majority, more than 80% of these patients will not have alarm features. Then what we do? We should evaluate is or is absent drugs and medicine that can cause gastritis. That aspirin and non-steroidal anti-inflammatory drugs. If not, that means we exclude drug-induced gastritis, type C, one of type C gastritis, yes? Another, what should we do? That we should exclude Helicobacter pylori. Here, we should use non-invasive test. It may be respiratory test or it may be antigen in the feces. We exclude Helicobacter pylori infection. That means that we exclude Helicobacter pylori-induced gastritis, gastritis type B. But in case when the Helicobacter pylori infection is present, but alarm symptoms absent, we recommend treatment. That is the Maastricht 5 recommendation, and for the same, test and treat. When the Helicobacter pylori is confirmed, we should recommend eradication treatment. But endoscopy and another is recommended in patient only with alarm symptoms or patient over there. This threshold age for different country difference. For Moldova, for example, it may be not official age, but 45, 50, as I said. And how to treat? We do not have specific special treatment. We should do this general recommendation. I explained you all this. Then we should do eradication of Helicobacter pylori when we confirm that is present. But when the Helicobacter pylori and drug-induced gastritis are excluded, then we should recommend, in case of type of functional dyspepsia with pain, we recommend the better recommendation is anti-secretory treatment. Anti-secretory with PPI or H2 blockers, or when there is not severe situation, anti-acids. But in case, I said about eradication, but in case of gastritis-like dyspepsia, with this fullness and with this ear resuscitation, the better selection will be gastroprokinetic drugs. You remember these drugs? That's domperidone, maybe old generation metoclopramide, and newest one, etoprade. In more severe situation, I explained you in general approach. It will be necessary maybe a combination, or it may be necessary another treatment using using antidepressants. Now, as usual, I finished my first part and I give you a link for test. The link is there. You have 10 minutes, a little bit less than 10 minutes for this test, then 15 minutes for break. And then at 1:50 or 50 minutes to 2, we will continue. Good luck. Okay, I am here. Are you here? May I continue? Thank you. Thank you, I see. Next part that we have to discuss is functional gallbladder and sphincter of Oddi disorders, or bowel system disorders. I can say that it is the most severe situation and maybe the most difficult, and that's only one functional disorders that can cause, after the certain time, can cause organic disorders. Why? Especially I'm saying about the sphincter of Oddi disorders. Do you remember the anatomy of bowel system, anatomy of this sphincter Oddi, and the functional disorder of sphincter Oddi? That's mean in majority of the cases spasm, long time spasm of sphincter Oddi. This spasm of sphincter Oddi causes the increase of pressure in bile ducts, and respectively, when long time the pressure will be increased, it may cause the organic changes in bile ducts and in the liver. But parallel, spasm of sphincter Oddi can cause increased pressure in pancreatic ducts, And this increased pressure can cause first acute pancreatitis, and you know that repetitive acute pancreatitis can cause chronic pancreatitis. That means that functional sphincter of Oddi disorders, in case of severe degree, long time persistence, can cause pancreatitis and can cause biliary hepatitis. Secondary cholestatic hepatitis. Not so frequent, but can. What about the criteria? Here, for according to the Rome IV criteria for these disorders, we have two different situations, E1 and E2. First situation, that is the situation with typical biliary pain, functional biliary pain. This functional biliary pain may be divided into functional gallbladder disorders That means biliary pain because gallbladder functional disorders, and biliary pain because of sphincter Oddi, biliary disorders. Another situation, this one, is with pancreatic pain. Pain, like in case of chronic or acute, more frequent chronic pancreatitis. And this, the same is caused by disorders of sphincter Oddi, but predominance with pancreatic increased pressure. Okay, what about the criteria for biliary pain? Criteria for biliary pain is pain in the epigastrium and or right upper quadrant. Not only right upper, maybe epigastrium. This pain is maybe really stable or increased in intensity, but at least 30 minutes or longer. This pain may occur in any time at different intervals and may be so severe that interrupt daily activity or lead to an emergency department visit. This pain may be enduring the night. This pain may wake up from sleep. And now think about this situation a little bit. 30 minutes of moderate or severe pain, waking from the sleep, that's real serious situation. That's a real, very low quality of life, and not several times per week. That's real bad condition. But we do not have any evidence of organic pathology. We do not have any evidence of gallstones or cholangitis or different organic structural changes, for example, like stricture or stenosis. No evidence of that. That's only functional, only spasm, or only atonic, hypotonic situation. And biliary pain doesn't have any relation with bowel movements or with postural changes or acid suppression. That means that we exclude that it is intestinal disorders or gastroduodenal disorders or pancreatic. What about, first of all, about the functional biliary pain and what criteria we have here? Functional gallbladder disorders. This means, first of all, this gallbladder must be not after surgical situation, not after cholecystectomy. And here we have criteria for biliary pain. This previous slide about the criteria for biliary pain. Here we have this criteria of biliary pain and absence of gallstones or other structural pathology, as I said. We have supportive criteria, adding criteria with low ejection fraction in scintigraphy of gallbladder and normal analysis. Normal enzymes liver and normal bilirubin and normal pancreatic enzymes. That is the functional gallbladder disorders. If to say simple, it will be on the pain practically. What is the functional sphincter of Oddi disorders? That means that we have the same, these criteria for biliary pain, but these criteria for pain are associated with elevated liver enzymes or dilated bile duct, but not both. If both, that will be signs of stenosis or some organic. This elevation of liver enzymes or dilated bile duct is not stable. Elevation of liver enzymes is usual short time. We have normal pancreatic enzymes, and when we do special examination, we see the abnormal manometry of sphincter Oddi. What is pancreatic sphincter Oddi disorders? It's clear that it will be pathology of pancreas. What does that mean? That we have pancreatic pain and documented recurrent episodes of pancreatitis. That must be typical pancreatic pain with amylase or lipase increase more than 3 times, and we have imaging, ultrasound, especially endoscopic ultrasound or MRI, evidence of acute pancreatitis. That means that we have the situation of biliogen pancreatitis, but not because of gallstones, but because of sphincter Oddi disorders. We exclude another etiology for this pancreatitis. We have negative endoscopic ultrasound, no ulcers, but confirmation of abnormal manometry, sphincter Oddi manometry. How to put diagnosis? We have the method, direct method, to put the diagnosis of disorder of sphincter Oddi. That method is sphincter Oddi manometry. Here you can see all what we need for this. That will be done using the retrograde endoscopical cholangiography, but not full cholangiography like this method. We introduce endoscope, we introduce the device with manometer in the sphincter Oddi and measure this sphincter Oddi pressure. You understand that that is invasive method, that's very serious examination, and we do not use this method for common, usual medical practice. For this task, we use the tactic to exclude organic. That means the diagnosis of functional disorders of biliary system is one of exclusion. We should exclude gallstones, biliary sludge, or small gallstones. We should exclude cholecystitis, pancreatitis of another etiology. Then we use laboratory tests to evaluate liver enzymes to confirm biliary sphincter Oddi disorder, or pancreatic enzymes, lipase amylase, to confirm pancreatic sphincter of Oddi disorder. We use ultrasound and endoscopy and another examination for exclusion of organic pathology. When organic pathology is excluded, we recommend treatment for functional disorders. First of all, this treatment will be a long time, not 1 week, not 2 weeks. The treatment will be 2 to 3 months, maybe 6 months in case of more severe situation. That is why we should recommend antispasmodic treatment, but the better way is to recommend selective antispasmodic. Antispasmodic that acts on level of the most on level of gastrointestinal tract, but the better on the level of sphincter of Oddi. And these antispasmodics are mebeverine and hemichromone with very high tropism to sphincter Oddi. But non-selective, like drotaverine, alverina, nifedipina, and so on, may be recommended only for short-term treatment or in case when they do not cause them serious adverse events. In case of gallbladder disorder and signs of the bile stasis of the bile in the gallbladder, we recommend choleretics and orthodesoxycholic acid. It's the same in case of hypokinetic situation, recommend prokinetics. But in case of serious stable sphincter Oddi spasm, may be recommended treatment with botulinum toxin, and this botulinum toxin must be introduced in the sphincter of Oddi. In more serious situation, may be recommended sphincterotomy. Sphincterotomy with or without stent drainage. When we are talking about the dysfunction of gallbladder, may be recommended cholecystectomy, but only in situation when was tried treatment with drug, with different medicine, and this treatment was not effective. And last one, what we have to discuss is intestinal functional pathology. If you remember, the in classification I said previous that here in functional intestinal disorders we have irritable bowel syndrome, functional diarrhea, and functional constipation. What difference? Why we need different form and functional bloating we have there. What different? Different is that irritable bowel syndrome, that is first of all pain, abdominal pain. In this abdominal pain will be associated with disorders of bowel movements. But functional constipation, that is only constipation and no pain. Functional diarrhea, that is only diarrhea and no pain. Functional bloating, that is only bloating and no pain. Is it clear? And functional diarrhea and functional constipation, that mean that this diarrhea or respectively constipation do not have any structural or metabolic or another etiological pathogenetical factors. And now, irritable bowel syndrome. IBS is the most common gastrointestinal disease in general in clinical practice. Throughout the world, the prevalence, the frequency of this disease is about 10 to 20% of adults, and is typical female predominance. The same, I can say that the most frequent causes for diarrhea is irritable bowel syndrome or functional diarrhea. What criteria we have? Do you see here? IBS, that's mean abdominal pain, recurrent abdominal pain. At least 1 day per week, at least once per week, and the same. In the last 3 months, here the criteria of time is the same. 3 months with the onset of 6 months before. But this recurrent abdominal pain are associated with 2 or more of the following criteria. 2 from 3 and 3 from 3. The pain has association with defecation. In majority of the cases, the pain appears before the defecation, but sometimes after the defecation. And pain is associated with change in frequency of stool, more frequent or less frequent than normal, or change in form of stool. The stool is constipated or diarrheic. I remind you this Bristol stool form scale that we used to evaluate the character of the stool. These 2 types for constipation, these 2 types for diarrhea, these 2 is normal. Sometime in function of a meal, these 2 the same may be normal. That means that IBS may be associated with constipation, with ABS, with diarrhea. Sometimes it may be mixed form, or sometimes unsubtyped or unclassified. What that mean? I show you here using this diagram. In case when the more than 25% of stools of defecation are of types 6 or 7 are diarrheic. That means we have IBS diarrhea. When more than 25 defecation are with stools types 1 or 2, that means we have IBS constipation. Do you see? Not majority of the defecation, more than 25%. When more than 25% are alterating or type 6, 7 or type 1, 2, but not normal, that means we have mixed. And when in majority of the cases, more than 25% stool is normal and only less than 25% stool is abnormal, that is unclassified IBS. How to put diagnosis? As in case of another functional disorders, we do not have criteria to put diagnosis. We should exclude organic intestinal disease. But to exclude organic intestinal disease is not easy. Do you remember my previous lectures? How to evaluate especially small intestine? But the colon the same. To be sure, we should do endoscopic examination of colon. That is not cheap. That is invasive method. And we can use for any patient with IBS, we cannot recommend endoscopic examination or another. Remember, 10-20% of adults have IBS. It's impossible to recommend any time endoscopic or another expensive, not cheaper examination and invasive examination. That is why our tactics is the same, like in case of another, to evaluate and exclude alarm symptoms. What alarm symptoms? Any blood is alarm symptoms. Any another pathological contents in stool, like pus, or using the coprological examination, leukocytes, erythrocytes, that is alarm symptoms. And here, attention, mucus is not alarm symptoms. Mucus is not the sign of inflammation. Mucus in the feces is the sign of irritation and is not alarm symptom. Then general symptom like weight loss, fever, that is or another general symptoms, skin manifestation, another manifestation, that is alarm symptoms, we need examination. Then, when the pain is not recurrent, when the pain is persistent, and especially in increased intensity, that means alarm symptom. When the pain appears during the night, awaken the patient from sleep. Awaken from sleep, that is the alarm symptoms for this intestinal disorder. For gallbladder, you remember, is not. Gallbladder may awake, another innervation. But here, awaken from the sleep is alarm symptoms. Any findings during the objective examination, you should evaluate like alarm symptoms. Hepatosplenomegaly, palpable mass in the abdomen, or another. Any changes in echogramma, in CBC, or in biochemical analysis, the same alarm symptoms. The signs of malabsorption is clear, that is the alarm symptoms. When we have alarm symptoms, when our patient has alarm symptoms, we should recommend examination. According to the previous recommendation from the previous lectures. But majority of the cases, more than 75%, more than 80% maybe in some population, the alarm symptoms will be absent. Then we evaluate the age of onset, and when the age is less than threshold age, less than 50 years, less than 45 years, for example, in our country, we recommend treatment. We continue this treatment for functional disorder, and in case when we receive relief of symptoms, of disappearance of symptoms, we can continue this treatment more than 1 month and 3 and 6 months. But in case when after 3-4 weeks of treatment, we do not receive relieving of symptoms, but opposite, we have aggravation of this situation, we should recommend, then only in these cases, we should recommend complete examination to confirm organic pathology or definitely to exclude this organic pathology. How to treat irritable bowel syndrome? The most important is, as usual, to establish a normal patient-physician relationship. Very important is explain that is not infection, that is not, parasitosis, that is not lambliosis or another situation, that is not chronic pancreatitis with exocrine insufficiency, because this condition is really rare, but that is only functional disorder. And then you explain the same, like in any case of functional disorder, lifestyle recommendation and dietary dietary modification. And only after that you recommend non-specific, but drug treatment. Here the same treatment will be long-time treatment. That is why we prefer selective, smooth muscle antispasmodics. Not selective, because these, like these, non-selective, like Debridat, papaverin, drotaverin, can cause, no, Debridat is selective, sorry, like papaverin or drotaverin can cause antispasmodic systemic effect, which will be not good, favorable for this patient. But selective, that's antispasmodics like athylonia bromide, pinaveria bromide, mebeverina hydrochloride, or Debridat trimembutine. In case of diarrhea, may be recommended anti-diarrheal agent, and in case of constipation, we recommend first of all fiber supplements or polyethylene glycol or lactulose to treat constipation. In severe situation, not frequent, less than 5, maybe about 5% of patients, we need more serious treatment using antidepressants. Okay, I finished the second part of my lecture the same. Now we have time to question. I in general finish intestinal disorders, and you have question, please, you can ask me. I will be here certain time. And now you have second part of your test for functional disorders in your chart. Yes, you can see the link for this second part. Answer, please. And if you have question, ask how you want, orally or write this question. And thank you for your attention. And good luck.
Thank you, Doctor.
Welcome, doctor.
Have a nice day.
The same you.